Okay, our next speaker, we're running a little bit behind, is Dr. Richard Campeau. He is our nuclear medicine physician at the Neuroendocrine group. He's former president of the Nuclear Medicine Society and is a critical element in treating people with I-131 MIBG. Richard.
Thank you. Thank you, Gene. President of the American Society of Nuclear Medicine, not the S&M. In any event, what I'd like to do in the next 30 minutes, hopefully, is to give you a little insight on using I-131 MIBG in neuroendocrine tumors. I have probably done well over 100 therapies in approximately 75 patients. So we'll go ahead and start with some of it. And okay, all right, all righty. High technology. Okay, this is my disclosures here. I am enrolled in a GE Healthcare program, funded research, both the I-123 MIBG, and the beauty is I-131 MIBG is done by practice of medicine. Essentially, I-131 is approved, MIBG is approved, and I essentially write a prescription or a directive to the people up in New Jersey. They prepare the I-131 MIBG, and I give it. Pretty much anyone can do it. Well, okay, so it's approved. Any clinician can use it. It's a non-toxic alternative. It can be used in conjunction with chemotherapy and radiation therapy. And it seems to work best in pheochromocytomas, paragangliomas, and mid-gut carcinoid tumors. And some background, as everyone in here knows, many patients, that neuroendocrine tumors are difficult to detect and commonly present, the patients do, with widespread disease. The neuroendocrine tumor patients, as you know, have a lot of metastatic disease and pretty much limited treatment options that will make a real difference. The mainstays, of course, are surgical debulking and somatostatin receptor blocking, respectively. Additional palliative therapies for other metastatic neuroendocrine tumors are as follows: systemic therapies, chemotherapies like and interferon alpha, etc., have really met with limited success in the low-grade neuroendocrine tumors and are better used in high-grade, poorly differentiated neuroendocrine tumors. The Nexivar, which is a Bayer product, essentially was produced, as the CEO of Bayer says, for the Western patients that could afford it. A year's treatment with Nexivar will cost about $96,000. And even the mTOR inhibitor, Afinitor, will still set you back $9,832 for 28 tablets. So these mTOR inhibitors and TK inhibitors are quite pricey. it's interesting, the $96,000 for the Nexavar treatment for a year corresponds to the Indian generic drug, which costs you about $2,800 for a year's therapy. 96,000, 2,800 for a year's therapy. There are additional therapies that we're well aware of, embolization, beginning with bland embolization and embolization with yttrium-90, microspheres, PRRT with both yttrium-90 and preferably perhaps is lutetium-177. Again, the smaller tumors for lutetium-177 and larger tumors perhaps for the yttrium-90 dotatok. This is a slide from the European Neuroendocrine Tumor Society and the World Health Organization. It's too busy and whatnot to read. I can barely read it here. But the interesting thing is you don't see I-131 MIBG in here as the, whoop, didn't want to do that. I see what people have the problem. You don't see the I-131 MIBG in there. So it's kind of interesting because I'll go into some things how I got started in this. This is a Trias scan here with indium-111 pentatriotide, and what you see normally, in fact, you don't see it normally. Oftentimes, the pituitary gland, you do see it with gallium-68, another somatostatin receptor analog. But we see pituitary, you see also faintly in the thyroid. You see liver and pretty intense in the spleen. You see the kidneys and you see bowel and urinary bladder. This is an example showing you what you do get with PET, where resolution is 4 to 5 millimeters versus about 1.2 to 1.5 centimeters with the gamma camera and Trias scan. See if I can do the pointer without the, yeah, the indium-111 pentatriotide really is done with a gamma camera, and you can see the advantage of using PET, gallium dotatate PET, picking up a lot more tumors, going over to lutetium-177 for therapy. You can also image it. And you do pretty good with gamma cameras. This really kind of gives you in a nutshell the real difference between a Trias scan versus a PET imaging agent such as gallium-68 dotatate. As you can see, huge amount of tumors picked up on the gallium. The other advantage is the gallium's done it in one hour or so, whereas the Trias scan, you got to do 4 hours because at 24 and 48 or even later, the bowel can present a problem. So you want to do the 4 hours, then you do 24. So you can see it's 2-3 days to do an Trias scan and a one-time 1 hour, 1 to 2 hour session for the gallium PET dotatate. And pretty soon we'll be using it standardly. Theranostics, and this is my definition, essentially it's a cutting edge of molecular medicine and personalized medicine where you use one molecule, say I-123, for diagnosis and turn around and make it I-131, and you use that molecule, same molecule, different isotope, for therapy. So that's essentially a good definition for Theranostics, using an agent that can be modified to do both diagnosis and therapy. Interestingly, let me see. This is a article that was written back in 2004 by a Vietnamese doctor in Paris, Charlie, but no pun intended. Charlie did this study, and it's pretty impressive in that you essentially have a complete response with the I-131 MIBG, and it got me pretty interested in looking at I-131 MIBG for those select patients that show a real intense uptake of I-123 MIBG. Again, you switch the molecule to I-131 MIBG, and you've got a therapeutic agent that works real well in selected cases. So a quick definition, what is MIBG? It's essentially a novel neuroendocrine analog labeled with either I-123 or I-131, and it's taken up by just a whole lot of neuroendocrine tumors, at least 70% of carcinoids and upwards of 85+% of PHEOs, with lesser in pancreatic neuroendocrine tumors in the 30% range. It's used as a tumor-targeted therapy, and it likely kills off the cells by internalized radiation, the beta particle that gives off the internalized radiation with a path length of somewhere around 2.4 millimeters. Pretty strong. They are stronger than lutetium, actually. This is a schematic picture of a synaptic neuron synapse there, and you see the amino acid tyrosine is used to make, if you will, norepinephrine. Norepinephrine is very much almost identical to MIBG, with a big difference. MIBG does not get out of the nerve terminal. It's stored in storage granules just like norepinephrine, but norepinephrine gets across the synaptic cleft to the receptors, whereas MIBG stays in that presynaptic sympathetic neuron and lets us see the integrity of the nervous system there. And that's the sense, the method of imaging on MIBG. So just to summarize some imaging procedures, suggested imaging procedures for patients with neuroendocrine tumors. Patient with a NET, you're going to use CT and or MRI. We like MRI better in the liver. And CT also in other places, particularly the abdomen, bowel, etc. The other thing which will be coming on strong is gallium-68 dotatate. That is a PET agent, and you get much better resolution. When major surgery is considered, and for some reason, the CT, the anatomical imaging modalities, MR, CT, or and even somatostatin receptor scintigraphy, gamma camera, Trias scan, if they're negative or equivocal, you want to go to gallium-68 dotatate, PET imaging, and not available everywhere, obviously, is F18 DOPA and the analog there, the methionine analog. But consider the old garden variety, F18 FDG, what we use in oncology now. F18 FDG is very good in high-grade, under-differentiated tumors. Doesn't work too well in the low-grade, which is the majority of the NETs, carcinoids, et cetera, but works real well if you've got high-grade, and even so in intermediate grade. And if the proliferation rate, the Ki-67 index, is greater than 10%, pretty much, 20 is high grade, but really above 10 is high intermediate, if you will, and FDG will be helpful in those high intermediate grade tumors. This is a combination of curves. There's a Kaplan-Meier survival with Ed Ochsner, mean survival of 189 small bowel NETs of 187 months. That's 15.6 years. Now, I say this is very select small bowels that are well differentiated, low grade. They may be stage 4. They present with all the Mets and all, but they are a select population of low grade neuroendocrine tumors, in this case small bowel NETs, which are predominantly the carcinoid tumors. The median survival is 236 months, or 19.7 years. And interestingly, if you look at the green curve, that's the expected survival of patients without a NET, and it's only about 5 years better with the in expected median survival for people without a neuroendocrine tumor. This is the I-131 MIBG cart that I roll up to the patient's room or into the radiology special procedures room when we're doing intra-arterial MIBG, say direct to a liver or to pelvic sometimes with intra-arterial iliac injections. It's composed of a lead-shielded infusion pump, absorbent pads, and I keep it downstairs in the MIBG hot lab. The experience here is survival for all NETs, not just those select small bowel NETs. These are NETs with higher grade neuroendocrine tumors, Merkel's, etc., small and large cell neuroendocrine tumors. And even in there, the median survival is somewhere around 120 months, or roughly getting close to 10 years, okay? The expected survival, again, for median is, as you saw before, in the approaching 300 months. this shows the actual survival of NETs with treatment of MIBG, and this is the survival of all NETs again. So interestingly, it's pretty close to the actual survival of small bowel NETs for the first 10 years. If you go out here, you'll see that the red line, which is the small bowel NETs, again is at least 20% better than the survival of all NETs, unselected NETs. So it is helpful to select your NETs for treatment of MIBG, but what happens is it's pretty close again out there for 9.8 years or so, and then it diverges if you're treating selected small bowel NETs. So what about use of tumor markers? And we like pancreastatin a lot, and it will decrease with MIBG therapy. As you can see, there is at least there's a 50 to 70% decrease in the MIBG treated patients with looking at pancreastatin. So the different ones are no treatment and then small amount. No. So even though these patients are getting a lot of other things, surgical debulking, somatostatin receptor blocking, etc., the MIBG does add on to the effectiveness, and you see that with significant decreases of pancreastatin, which is an indicator of tumor bulk. This is a quick picture of our group there. It's a little bit older there. You see Dr. Lowell Anthony in the middle next to Gene Waltering and myself and whatnot. But essentially, this is our tumor team there. This is our map with patients throughout the United States, and many of which are here. And this is essentially the first patient I ever treated with I-131 MIBG. She is a lady now living up in Kentucky area, but she is now 8 years out. She may be in the room here, I'm not sure, but she's done quite well. In fact, I treated her in 2008, and then I treated her again in 2014. So the I-131 MIBG is relatively non-toxic. It tends to hit the bone marrow more than the kidney, and lutetium, the dotatoxinol, dotatate, and whatnot, yttrium-90, will hit the kidneys more, as you know. So that wraps up there. I think I've pretty much stayed on time. Thank you.